In our headlines this morning, hospitals and doctors around the country are reportedly calling out the federal government for what's being called an uneven and opaque method of distributing its supply of the Gilead drug Remdesevir. According to Stat News, about 24 hospitals are believed to have been chosen to receive the drug so far. But clinicians say it's unclear why some were chosen to receive coveted doses while others were not. And who's making those decisions in the first place? Joe.
Thanks, Beck. Meantime, New York Governor Andrew Cuomo shared a startling statistic yesterday citing early data from about 100 hospitals. He said roughly two-thirds of the new coronavirus hospitalizations are people who've been staying home. Joining us to talk about this and much more, Dr. Scott Gottlieb, former FDA Commissioner. He's also a CNBC contributor and serves on the boards of Illumina and Pfizer. Like so many things, Doctor, that is one data point that seems to imply some type of cause and effect, but there are other parameters as to where these people were and the closeness of their associations and everything else, I think. Do you glean anything from this about the characteristics of the virus?
Well, look, it's a high statistic in terms of the origin of the infection in a lot of people. But when we look at the data in China and where the clusters of infections happened in China, and they have very good reporting coming out of China now around that, a lot of the infections happened either on mass transit or in the home. What happened was someone brought the virus into a home, and then other people in the house became infected. So when you look at clusters of infection where more than one person became infected, it was usually either on mass transit or in the home, sometimes in workplaces as well, but mass transit and the home were the top two places where clusters happened. So in that context, the New York data isn't all that surprising. What's happening is a lot of people who can't social distance or live in crowded housing situations, they can't self-isolate in their home. That's where we're seeing a lot of spread happening.
I kind of take that as a mixed blessing almost, Doctor, because so few cases seem to have been transmitted outdoors, even though we've heard that it can go 10 feet, the droplets or whatever. But the more we hear, it seems like it's close contact is what really spreads the virus. I was shocked at the number of individuals that work at some of our meat processing plants I mean, seriously, they're like pockets of infections there, and they're working right next to each other in close proximity. And I guess that's why what we've done in terms of social distancing is working, but at home you don't social distance.
That's right. It's close contact, and it's actually sustained close contact. So the studies show that the longer you're in contact with someone, the higher the risk of infection. That seems intuitive, but there's actually pretty good data on this right now. And when you look at flu incidents each year, and you look at who gets the flu actually disproportionately affects certain groups of people, disadvantaged Americans, people who work in jobs where they can't socially distance. So people who work on shop floors or in warehouses or in grocery checkout lines, they get disproportionately impacted by the flu. Now, we don't pay attention to that because we're oddly complacent about the flu, and a lot of us end up getting the flu. But COVID's going to be no different. COVID's going to hit certain groups of people harder, people who are in institutions like nursing homes, in prisons, people who live in housing conditions where they can't self-isolate at home, and people who work in jobs where they work close to other people and can't, socially distance on the workplace. So I think we need to think about how to get protective equipment into those kinds of settings. Maybe think about a refundable tax credit or other kinds of policy measures so that businesses that might not have a big margin, they operate at slim margins. So think of like a grocery store, can be spending the kind of money they need to get testing into the site, to the work site, get protective equipment into the work site, because a lot of white-collar jobs are going to have those capabilities. They'll be telecommuting. They'll have, testing in the workplace or accessible to their employees. They'll hand out PPE and Purell. A lot of businesses where the actual risk is, think of a warehouse or a shop floor, they're not going to have the same margin to be able to do that.
Becky.
Dr. Gottlieb, you mentioned that it's transmitted in houses, and I read some of those statistics, too. I think you were tweeting some of the threads I was reading through on that, where they talked about how it's spouses who get it most often, but kids are picking it up, too, and that was a little surprising, just the number of kids that are getting it because they're in close contact with people, their parents who have brought it home some way or another. How concerning is that, or do they get it with much less severe circumstances?
Well, the kids from what we can tell, aren't getting as sick, and most of it must be asymptomatic spread because the actual number of children who are reporting with coronavirus active infection is very low. There's mixed studies on this. Some studies say the kids aren't getting infected, others saying that they're getting infected and they're vectors, but they're getting sort of subclinical illness. They're not really manifesting symptoms of coronavirus. We now see some features that have been reported on in the last few days of what looks like a post-viral syndrome. Looks like a syndrome that kids are getting after they get infected with coronavirus. So they're getting infected, it's not really identified, they're not getting sick, but then after the illness subsides, they're getting a sort of autoimmune type phenomenon, an autoimmune type condition that looks very concerning and is very concerning. What we don't know is the denominator. So we know the numerator, that a couple of dozen reports now of this syndrome, but it might be that thousands of kids are actually getting coronavirus, tens of thousands of kids, and we just aren't seeing it because the kids are getting a very mild illness or they're getting no illness at all. But they're still vectors. They're still passing on the virus. And that's, in fact, why the schools were closed, because the first thing you do in an influenza pandemic is close the schools. There's a lot of good data showing that the scope of a flu epidemic goes down dramatically when you close the schools because the kids become vectors inside the community for passing on the virus. And we assumed the same thing was true of coronavirus. We don't have data yet on that.
Well, Doctor, I remember, I never really believed Easter, obviously, but that date was broached as, as a reopening or resurrection or however you wanted to characterize it. Then May 1st, I remember when it was May 1st, and then in mid-April it got moved to May 15th. And at that point I said, May 15th, and now here we are, what is it, May 7th or whatever it is, and I never know what day it is anymore, so forgive me if it's not May 7th. I think it is. When was Tuesday was, I think it was.
Yeah, you're right.
So it is the 7th.
Right.
So now May 15th sounds just no way. And what's happening? We're bending obviously we're bending the curve down, but it's slowly moving across the entire nation, almost geographically, with hot spots and rises in incident when it cools down in other places. I mean, are we looking now well into midsummer before a lot of places have any reopening whatsoever in your view? And the death toll, that is, goes down in New Jersey and New York, but it gets made up somewhere else. There's that horrific total every day.
Look, when the president announced that we were extending the stay-at-home orders and the closures to the end of April, I think a lot of people from a public health standpoint felt good about that because we felt that by the end of April, we were not only going to bend the curve, flatten the curve, but we were going to see sustained declines in new cases and be in a much better position nationally. Outside of the New York region, we haven't seen that, and the Pacific Northwest parts of California. We haven't seen nationally really the sustained declines that we expected. And we might not see it. We might just see this slow burn of infection across the country. It's still going up in about 20 states, a little bit more than that now. Not a lot, but it's continuing to go up. It might start to level off as we head into the summer, but we don't know. But against this backdrop, you were reporting this morning on the economic hardship. I'm seeing the public health implications as well. Visits for chemotherapy are down almost 20%. Vaccine prescriptions are down almost 90%. We're going to end up having probably measles outbreaks because kids are skipping routine vaccinations and routine physicals. So there's a public health consequence on the other side of this, and we have to just start weighing those and ask ourselves how much we're willing to tolerate to try to get the virus down to lower levels. I'd like to see it at lower levels than where it is now. Mitigation work to prevent the hospitals from being overwhelmed, but we still have a lot of infection, and as we reopen against that backdrop, we're going to risk outbreaks. But I think going through May, we're going to take that. A lot of states are going to take that chance. You already see Florida, Georgia, other states doing that, where they know they still have a lot of spread. They're opening against that backdrop and hoping the precautions that we put in place in our normal lives are going to help mitigate that spread and keep it from getting worse.
Andrew.
Doctor, in terms of timeline, one of the things we talk about all the time is the fall. Just get us to the fall, and we're going to open schools and things will get better, all of it. I don't want to suggest that's an artificial timeline. It's a timeline we all need. The question is whether you think the technology, the testing, all of the bets that we're having to make to do that are going to be in place by then, and what leads you to believe that we will be there in time?
Look, I want to get to July and August because I think hopefully this summer is going to be a backstop and there is a seasonal effect here. If there's not, this is going to be far, far more challenging, and there's reason to believe that there is some seasonal aspect to this. You look in South America right now, and you're seeing this become epidemic in countries like Brazil. So there does seem to be a seasonal component to this. The fall worries me a lot. I think our toolbox is going to be a lot better. We have Remdesivir now. We'll have it in quantity, so it'll be produced in larger quantities. We won't have this issue with the distribution, the government holding on to the supply. We should have the antibody drugs at some point in the fall, again in quantity, to help people who get sick, to help rescue people who have conditions that predict the worst outcome, that leave them more vulnerable. I think we'll have one or more vaccines available in quantity sufficient to mass inoculate a population experimentally in the context of a trial, but if there's an outbreak in a large city. So that's a pretty good toolbox. I think we're going to have very robust testing. We're not going to be talking about the inability to get people tested. Testing's going to be, hopefully, in the community, in the workplace, so we'll be able to get people tested. And then, we should be investing in track and trace. This is controversial. There's a lot of pushback, frankly, on the political right of doing track and trace, where you isolate people who are infected. You try to track down their sick contacts. People say, well, there's just too many people. We're never going to keep up with it. That is true. There's going to be a lot of people. We're never going to keep up with all of it. But even if we can keep up with a fraction of it, even if we can identify and self-isolate, 20% of the people who are infected with this, that's going to have downward pressure on the transmission rate and keep this epidemic from getting worse.
All right, Dr. Gottlieb, thank you. Again, we'll see you, what's today, Thursday?
Thanks.
Maybe tomorrow, if not, I'm sure on Monday. Hopefully tomorrow. Thanks. Andrew.
Thanks.
Okay. Coming up, when we return.